Uh, Thank you very much, and I'm extremely grateful to Professor Tipu and his team for their gracious invitation to be a part of this wonderful academic event. And I'll be talking about the cardiac PET, seeing beyond the perfusion. And regarding this presentation, I have no conflict of interest to declare, but let me admit that I have taken some material from the website of the American Society of Nuclear Cardiology. As we know that the PET MPI, that is positron imaging tomography, has revolutionized the nuclear cardiology because the PET tracers have significantly better pharmacokinetics and shorter half-life, like the rubidium-82 having a half-life of just 76 seconds, ammonia 10 minutes, oxygen 15, water 2 minutes, and recently introduced fluoroperidase, which is labeled with fluorine 18, having a half-life of 110 minutes. And because of these properties, it not only gives the good quality or high quality images, but it also enables us to precisely calculate the blood flow and the left ventricular function. Similarly, the myocardial viability is basically assessed by using the fluorodeoxyglucose, which is still considered as the gold standard for the detection of the hibernating myocardium. And finally, we can use the CT images to assess the coronary artery calcium and cardiac chamber morphology. In the next 15 minutes, we'll be discussing the strengths of the myocardial perfusion imaging with PET, and we'll also see the various factors contribute to these strengths. The excellent PET MPI has excellent diagnostic accuracy, as it has been shown by the Pacific trial, which was published in 2017, including 208 patients who had head-to-head comparison with the CT angiography spec with the tetrophosphine and PET MPI using the oxygen 15 water. And in this trial, they kept FFR measured by the coronary angiography less than 0.80 as a significant obstruction. And the result showed that the PET MPI has a diagnostic accuracy of the 85%, followed by SPEC CT 77% and CT angiography 74%. PET also gives the excellent image quality thanks to the robust scatter correction and attenuation correction. A special resolution is good for rubidium, which relatively have larger soft tissue penetration of the positron, but it is excellent for the ammonia and the fluoroperidase, which has a shorter positron range. Similarly, the myocardial tracer uptake is impacted by the role of phenomena which is somewhat exists in the rubidium-82, which is an analog of the thallium-201. Therefore, the uptake is moderate, but it is high for the ammonia and the oxygen and the fluoroperidase because excellent for the oxygen 15 because it freely diffuses through the myocardial cell membrane. Therefore, the robust attenuation correction, scatter correction, and the high spatial resolution, these are the three factors which impart significantly high specificity to its PET MPI, that is in the range of the 89%. Similarly, this is a normal rubidium MPI study. We can see that the left ventricular cavity is very well outlined. Left ventricular myocardium is outlined. We can see subdiaphragmatic activity, which can be eliminated out while analyzing the images. This is a normal ammonia image. Here we can see that the left LV cavity is relatively larger because of the better resolution. LV cavity is well outlined, and similarly we can evaluate, we can assess the papillary muscles at 2 o'clock position in these scans. This is a recently introduced fluorine 18 fluoroperidase agent which has been approved by the FDA for the MPI, and again the quality of the image is significantly good with delineation of the papillary muscles at 2 to 3 o'clock position as well. We know that the PET cardiac tracers has excellent pharmacokinetic. At this point, we must recall the phenomena of the role of effect, which was considered as one of the major limitations in SPECT MPI because at high coronary flow, the PET tracer were used to be lessly taken up by the myocardial cells like the thallium and the system. But this role of phenomena is relatively less with rubidium-82 and significantly low for the ammonia and the fluorpyridas, and it is negligible for oxygen-15 water because it freely diffuses through the myocardial cells. So the trade-off phenomena, which was a problem for the SPECT tracers, it's not a big problem for the PET tracers. And because of the high myocardial extraction of radio tracers of the PET, assessment of the left ventricular function at peak stress and the absolute myocardial flow, and assessment of the coronary flow reserve. These three factors again impart the high sensitivity of PET MPI, that is 90%. Because of the shorter half-life of the PET radio tracer, it is possible to conclude the whole stress and rest imaging protocol within short span of time. It depends upon the half-life of the tracer, like the rubidium-82 has a half-life of the 76 seconds. Therefore, the rest and the stress PET MPI can be concluded within 20 to 3 minutes. And for ammonia, which has got a half-life of the 10 minutes, rest and stress PET MPI can be concluded within 1 hour time. Recently introduced fluorine-18 fluorpyridas, which has got a half-life of the 110 minutes. Again, with this tracer, stress and the rest MPI, a PET MPI can be concluded within 2 hours, and these times or the protocol time is significantly less as compared to the SPECT MPI, which usually takes 4 to 6 hours to be completed if you are using a one-day protocol. Radiation exposure by the PET tracer to the patients and the general staff is significantly low. As we recall that American Society of Nuclear Cardiology in 2010 issued an advice for the nuclear cardiology laboratories to adopt those protocol and use the dose of the SPECT tracers to keep the radiation exposure less than 9 millisieverts. But despite of all efforts, the data have shown that in 2015, the radiation incurred by the SPECT MPI to the patients were about 15 millisievert, which was significantly high. And for dual isotope technique, that is using the tetrophosphine plus thallium-201, it was much above the 30 millisievert, which was absolutely against the ASNC guideline. But during the same period, we can see that the PET in 2015 was able to give radiation exposure less than 5 millisievert, which was well within the recommendation of the American Society of Nuclear Cardiology. And this part of the cardiac PET MPI is very important for the younger population, because now the recent data have shown that medical imaging radiation exposure increases the chances of the second primary malignancy in 5 to 10% of the pediatric and adult population. So this is a very important finding as well. During the vasodilator stress and PET MPI, we can assess the left ventricular ejection fraction, because at peak stress or the peak vasodilatation, we can calculate the left ventricular ejection fraction, and when it is divided by the resting ejection fraction, that gives ejection fraction reserve. And a large body of the data has shown that if the left ventricular ejection fraction is greater than 7, then the likelihood ratio for the coronary artery disease is significantly low. Similarly, if there is a decline in the left ventricular ejection fraction reserve, it has an inverse correlation with Duke angiographic jeopardy score, which means that with the decline in the left ventricular ejection fraction, more and more amount of the myocardium is putting towards the myocardial ischemia and injury. In a paper which was published in 2007, this point was again categorized that a normal left ventricular ejection fraction, that is 5 or more than 5%, has a 97% negative predictive value to exclude the left main and 3 vessels disease. As we know that the coronary circulation does not depend only on the epicardial vessels. It also depends on microcirculation, that is the small vessels, and in this regard, assessment of the myocardial blood flow reserve is very important finding, because during the vasodilatation, we can measure the pressure gradient difference, and when the coronary flow reserve during the vasodilatation divided by the resting blood flow, that gives the coronary flow reserve, which has not only the diagnostic importance, it also has the prognostic and helps the treating physician in deciding between the medical management and revascularization. Like the study which was published by Naya in 2014, they showed that a normal myocardial flow or the coronary flow reserve more than 1.93 has 97% negative predictive value to exclude high-risk coronary artery disease. This is a 46 years old lady with all risk factors and atypical chest pain, coronary angiography revealed all three coronaries are showing the non-obstructive coronary disease. But the stress MPI using the rubidium 82, we can see that although the left ventricular function is normal, but there is an element of the transient ischemic dilatation along with the global CFR of 1.3, which is low. So that concludes that although the perfusion is normal, but the transient ischemic dilatation and global CFR 1.3 is an indicative that this patient is having the small vessel disease with non-obstructive epicardial vessels. In a study which was published by Patel upon more than 12,000 patients, they have also found that if the coronary flow reserve is more than 1.8, then these patients would have significantly low major and minor cardiac events in the rest of the life, as compared to those who have coronary flow reserve equal or less than 1.8, starting from the 1% of the ischemia or the 10% of the coronary artery disease, they will be having the significantly higher cardiac event rates. And in this study, they have also mentioned that for every 0.1 unit decrease in coronary flow reserve, it was associated with 9% hazards for cardiac deaths. In the same study, the Patel has mentioned that the CFR also helps the treating physician to decide whether the patient should go for the revascularization or medical management would be suffice. Like they mentioned that if the coronary flow reserve was equal or less than 1.8, and if these patients had the revascularization within 90 days of the revascularization, they had the significantly better survival benefit as compared to those who did not have revascularization within 90 days despite of less than 1.8 coronary flow reserve. So important thing is that a normal coronary flow reserve excludes the obstructive coronary artery disease, excludes the presence of the small vessel disease, and it also helps the physician to decide that this patient is not a candidate for the revascularization because the coronary flow reserve is normal. And finally, the normal coronary flow reserve also helps the physician to find the adequacy of the vasodilator stress test during the PET MPI. By using the CT images of the PET MPI, we can look over the coronary artery calcification. Like in this example, all three major coronary vessels in the left main, they are showing the dense calcification, and you can also look over the morphology of the cardiac chambers. Myocardial viability, as we know that for the last 10-15 years, fluorodeoxyglucose is considered as the gold standard for the detection of the hibernating myocardium. And in combination with PET MPI, the metabolic imaging using the fluorodeoxyglucose, if there is an ischemic defect which is showing the viable or the persistent metabolic activity, this perfusion metabolism mismatch is considered as a hallmark for the detection of the hibernating myocardium, and these patients usually qualify for the revascularization. In addition to the coronary artery disease, FDG PET-CT also helps in a non-cardiovascular involvement. Like in this patient, we can see that there is an enhanced or the diffuse metabolic activity around the cardiac pacemaker and its lead, indicating that the site of the implant is infected. Similarly, on the right, we can see that there is a hypermetabolic focus over the cardiac valve, indicating the infection. And unfortunately, there was a septic embolus which was involving the spleen of this patient as well. So we conclude that the PET MPI has excellent sensitivity and specificity, excellent image quality. It has excellent efficient imaging protocol because of the shorter half-life. And finally, we can use the different parameters for the diagnosis and the decision making. Thank you very much, ladies and gentlemen.